Hi, class, and welcome to chapter 21. This is on the respiratory system. I've included all three parts, and I'm going to skip over some of them, but part A has to do with all of the anatomy. It's a review from anatomy of the respiratory system, and then part B and C is more about respiratory physiology. I'll skip some things in these PowerPoints, but a lot of the material is pertinent and important for you to know. So respiratory physiology, we have to understand what goes into inspiration and expiration. Inspiration is gases flowing into the lungs, and expiration is gases flowing or exiting the lungs. Atmospheric pressure is the pressure exerted by the air surrounding the body. Respiratory pressures are described as relative to atmospheric pressure, and that's usually abbreviated PATM. Negative respiratory pressure is less than PATM atmospheric pressure. Positive respiratory pressure is greater than atmospheric pressure, and zero respiratory pressure will be equal to atmospheric pressure. Intrapulmonary pressure is the pressure in the alveoli. It will fluctuate with breathing and it eventually will equalize with atmospheric pressure. This intrapleural pressure, pressure in the pleural cavity, it fluctuates with breathing. It's always a negative pressure. Fluid levels must be kept as a minimum, so excess fluid is always pumped out of the body by the lymphatic system. And if fluid does accumulate, a positive intrapleural pressure will develop, and that's when a lung could collapse. There's two inward forces promoting lung collapse: the lung's natural tendency to recoil. Because of its elasticity, lungs always try to assume their smallest size, and the surface tension of alveolar fluid, the surface tension will pull on alveoli to try to reduce their alveolar size. One outward force tends to enlarge the lungs, and that's the elasticity of the chest wall that pulls the thorax outward. And negative intrapleural pressure will be affected by these opposing forces, but will be maintained by strong adhesive force between parietal and visceral pleural. Transpulmonary pressure has to do with the pressure that keeps your lung space open. So this keeps your lungs from collapsing. The greater the transpulmonary pressure, the larger the lungs will be, and the lungs will collapse if the intrapleural pressure will be equal to transpulmonary pressure, or if the intrapleural pressure is equal to atmospheric pressure. So a negative intrapleural pressure must always be maintained to keep your lungs inflated. And that's just what this is describing here. The intrapulmonary pressure must be, or the intrapleural pressure again must be negative to keep your lungs from collapsing. A pneumothorax is rupturing either the parietal or the visceral pleura. This can cause a pneumothorax, which gets air into the lungs, basically. So air will be inside the pleural cavity, and this will cause the intrapleural pressure to become equal to the intrapulmonary pressure, and as a result, the lungs will collapse. Atelectasis is lung collapse due to a plugged bronchioles, which will cause collapse of alveoli, or a pneumothorax, which is air in the pleural cavity. It can occur from either wound in the parietal pleura or the rupture of the visceral pleura, and it's treated by removing air with chest tubes. And when the pleura heal, the lung will reinflate. Pulmonary ventilation consists of inspiration and expiration, so that is one breath. It's the mechanical process that depends on volume changes in the thoracic cavity. The volume changes lead to pressure changes, and the pressure changes lead to the flow of gases to equalize pressure. We talk a lot about Boyle's law to help describe the relationship between pressure and volume of a gas. And this just, Boyle's law refers to the fact that if the amount of gas is the same and the container size is reduced, pressure will increase. So pressure will vary inversely with volume. So that means as pressure increases, volume must decrease and vice versa. And that makes sense. If the volume of the room you're in increases, the pressure will decrease. Inspiration is the active process involving inspiratory muscles. We have the diaphragm. It's a dome shaped. When it contracts, it will move inferiorly and flatten out, which will result in increased thoracic volume. And the action of the intercostal muscles: when the external intercostals contract, the rib cage is lifted up and out, much like when the handle on a bucket is raised. And it will go outward as it moves upward, and that results in an increase in thoracic volume. So this just kind of shows the way the muscles will move, the diaphragm and the external intercostals, and then the muscles of expiration, the way they will move to either increase thoracic lung capacity or decrease. As thoracic cavity volume increases, lungs are stretched as they're pulled out of the thoracic cage. And during this time frame, pressure will drop, so the air will be sucked in via inspiration. Forced or deep inspirations can occur during vigorous exercise or in people with chronic obstructive pulmonary disorder, COPD. Accessory muscles will also be activated as lifted there, and they just act to further increase the thoracic cage size, creating a larger pressure gradient so more air can be drawn in. And this just shows the sequence of events during inspiration and expiration. Expiration is quiet expiration is normally a passive process. The inspiratory muscles relax, thoracic volume decreases, and lungs recoil. Forced expiration is an active process that uses oblique and transverse abdominal muscles as well as internal intercostal muscles. And these are the steps or sequence of expiration. Changes in intrapulmonary and intrapleural pressures during inspiration and expiration. I'm not going to ask you guys to know the specific changes of each, but you can kind of see the difference of changes in the intrapulmonary pressure and intrapleural pressure during the course of one breath over about 5 seconds. Non-respiratory air movements, many processes can move air into or out of the lungs besides breathing, and they may modify normal respiratory rhythm. Most result from a reflex action like coughing, sneezing, crying, laughing, hiccups, or yawns. 3 physical factors influence the ease of air passage and the amount of energy required for ventilation: airway resistance, alveolar surface tension, and lung compliance. Airway resistance has to do with friction, which is the major non-elastic source of resistance to gas flow, and this occurs in airway. There's a relationship, as shown here by that equation, between the flow, the change in pressure, and resistance, which I don't expect you guys to know. Airway resistance in the respiratory tree will depend on 2 things: the diameter of the airway. In the first part of the conducting zone, they'll be huge, and progressive branching of airways as they get smaller leads to an increase in total cross-sectional area. Any resistance usually will occur in medium-sized bronchi, and resistance will disappear at terminal bronchioles where diffusion is what drives the gas movement. So this just shows where the increase in resistance is usually the highest or greatest, and that's again in medium-sized bronchi. The conducting zone again refers to all the bronchioles that take air through them, and the respiratory zone has to do with the alveoli and gas exchange. As air resistance rises, breathing movements become more strenuous. There can be a severe constriction or obstruction of bronchioles, and this can prevent any sort of life-saving or life-sustaining ventilation. And this can occur during acute asthma attacks and stop ventilation. Epinephrine usually dilates your bronchioles and reduces air resistance, so that's usually given during an asthma attack. Alveolar surface tension has to do with the attraction of liquid molecules to one another at a gas-liquid interface. It tends to draw liquid molecules closer together and reduce the contact with dissimilar gas molecules. It will resist any force that tends to increase the surface area of the liquid, and water, which has a very high surface tension, coats the alveolar walls in a thin film, and this will tend to cause your alveoli to shrink to the smallest size, that is, to collapse. But we have surfactant, which is the body's detergent-like lipid and protein complex that helps reduce surface tension of alveolar fluid. And surfactant will help prevent alveolar collapse, and it's produced by your type 2 alveolar cells. Insufficient surfactant is common in premature infants, and this can cause infant respiratory distress syndrome, where there's increased surface tension resulting in the collapse of alveoli. The alveoli must be completely reinflated during each inspiration, and this is common in premature babies whose lungs aren't fully developed because they are not producing adequate amounts of surfactant. Usually they don't do that until the last 2 months of development. So a treatment is just to spray natural or synthetic surfactant into a newborn's air passages to help with that. Lung compliance is a measure of change in lung volume that occurs with given change in transpulmonary pressure. It's normally high because of the distensibility of lung tissue and also surfactant, which decreases alveolar surface tension. Higher lung compliance means it is easier to expand the lungs. You don't need to know how it can be written mathematically as. I want you to know how compliance can be diminished by scar tissue like fibrosis, reduced production of surfactant, and decreased flexibility of the thoracic cage. Any decrease in the natural resilience of the lungs diminishes lung compliance. Chronic inflammation like tuberculosis can cause fibrosis, which is scar tissue to replace normal lung tissue, and a decreased production of surfactant can also impair lung compliance. The lower the lung compliance, the more energy is needed just to breathe. All right, they can also be decreased by deformities of the thorax, ossification, common in old age of your costal cartilage, or paralysis of your intercostal muscles. Then there are several respiratory volumes that can be used to assess respiratory status. And I do want you to know these. Respiratory volumes can be combined to calculate respiratory capacities. Um, and respiratory volumes and capacities are usually abnormal in people with pulmonary disorders. So we use a spirometer, which is an original cumbersome clinical tool used to measure patients' respiratory volumes. We have electronic measuring devices used today, but we can measure someone's tidal volume, which is the amount of air moved into and out of the lung with each breath, averages about 500 milliliters. The inspiratory reserve volume is the amount of air that can be inspired forcibly beyond the tidal volume. The expiratory reserve volume is the amount of air that can be forcibly expelled from the lungs. And the residual volume is the amount of air that always remains in the lungs. And if there's always a little air needed to keep the alveoli open at all times. There's combinations of two or more respiratory volumes. The inspiratory capacity is the sum of tidal volume and the IRV, inspiratory reserve volume. The functional residual capacity is the sum of those, the vital capacity, and then total lung capacity. These are all capacities, just showing the sum of different lung volumes. And probably to better describe how we get capacities, is showing a spirographic record for a male. So here's normal tidal volume in this light blue color. The inspiratory reserve volume is up high and the expiratory reserve volume is there, with the residual volume is down here. And on the y-axis, we have millimeters of air that we're measuring. And different capacities are measured by adding up what is seen in brackets here. And this is just something good to know in general. So I do want you to understand a chart like this. I've tried to find you a lab of the respiratory system, but I haven't yet. So I do want you to know this chart and what these capacities mean. And this is just another description of the respiratory volumes and capacities and what they're all equal to. But I like looking at a chart like that to more see how they are determined. Anatomical dead space does not contribute to gas exchange. It's air that remains in the passageways. Alveolar dead space is space occupied by non-functional alveoli. It's usually due to collapse or obstruction. And total dead space is the sum of anatomical and alveolar dead space. Obstructive pulmonary disease is increased airway resistance, and restrictive disease is reduced total lung capacity due to disease or exposure to environmental agents that can cause fibrosis. Pulmonary function tests can also measure the rate of gas movement. So your forced vital capacity is the amount of gas forcibly expelled after taking a deep breath. And the forced expiratory volume is the amount of gas expelled during a specific time interval. FEV1 is the amount of air expelled in the first second. Minute ventilation is the total amount of gas that flows into or out of the respiratory tract in a minute. Normally, it's about 6 liters. It can be up to 200. An alveolar ventilation rate is the flow of gases into and out of the alveoli during a particular time. AVR takes into account the amount of dead space, tidal volume, and rate of breathing. I won't have you guys understand this, but Significant increases in alveolar ventilation are brought about by increasing tidal volume rather than frequency, and rapid shallow breathing could actually decrease the alveolar ventilation. Gas exchange, then, we'll talk a lot about this in part C, but occurs between the lungs and blood, as well as blood and tissues. External respiration is the diffusion of gases between blood and lungs, and internal respiration is the diffusion of gases between blood and tissues. And they're both subject to basic properties of gases and the composition of alveolar gas. We'll get a little bit into partial pressure, but you guys don't need to know the partial pressure properties of gases or Henry's law and any sort of mathematical compositions. The composition of your alveolar gas, though, so this is the air in the alveoli, they normally contain more carbon dioxide and water vapor than atmospheric air because of gas exchanges in the lungs. So oxygen will diffuse out of the lung and carbon dioxide diffuses into the lung. Also, the humidification of air by the conducting passages and mixing of alveolar gas with each breath. External respiration involves the exchange of oxygen and carbon dioxide across respiratory membranes, and it'll be influenced by different pressure gradients, gas solubilities, thickness and surface area of respiratory membrane, and ventilation perfusion coupling. And I'll skip over this. You guys don't need to know this. These are showing the different gradients, and just showing these different partial pressure gradients allow gases to diffuse either into the capillaries, going back to the heart, or out of the capillaries into the lungs. So you can see here in general the difference or the amount of partial pressure gradients promoting gas exchange. So when you inspire air, that air is mostly all oxygen and no carbon dioxide, so that it will diffuse easily into the capillaries. Carbon dioxide that comes into your lungs will diffuse easily back into the alveolar air. Oxygenation of blood in pulmonary capillaries at rest is shown here. Time in the pulmonary capillary, again showing just how oxygen travels in to your pulmonary capillaries. The thickness and surface area of the respiratory membrane also attributes to external respiration. The respiratory membranes are extremely thin, and there's a large total surface area of the alveoli. It's about 40 times the surface area of the skin to just try to help with this gas exchange. Effective thickness of the respiratory membrane increases dramatically if the lungs become waterlogged and edematus, which is kind of swollen or filled with fluid. This is seen in pneumonia or left heart failure. The 3/4 seconds that red blood cells spend in transit through pulmonary capillaries may not be enough for adequate gas exchange, and this will result in body tissue suffering from oxygen deprivation. Some pulmonary diseases drastically reduce alveolar surface area, like in emphysema. The walls of the adjacent alveoli break down and alveolar chambers enlarge. Tumors, mucus, or inflammatory material also can reduce surface area by blocking gas flow in the alveoli. This is a look at a normal lung and a lung with emphysema. You can see kind of the blockages built up and also the deterioration of the alveoli. Ventilation perfusion coupling has to do with perfusion, the blood flow reaching the alveoli, and ventilation, the amount of gas reaching the alveoli. Ventilation and perfusion rates must be matched for optimal efficient gas exchange, and they're both controlled by local autoregulatory mechanisms. And that's all you really need to know about perfusion and ventilation. Okay. Internal respiration involves capillary gas exchange in body tissues. These are partial pressure gradients, again, promoting gas movements in the body, showing internal respiration, the air moving out of the capillaries into the tissues, and carbon dioxide, the waste from cells, moving back into the capillaries to be taken back to the lungs to be exhaled. We're also going to, I think in this PowerPoint, I want to take you through a couple things I want you to know in part C of this chapter as well. And again, part A, use that to review the anatomy. This part C talks a little bit about the transport of respiratory gases by blood. We know that molecular oxygen is carried mostly bound to the iron in hemoglobin in red blood cells. This takes us through the association of oxygen and hemoglobin. Basically, each hemoglobin molecule is composed of 4 polypeptide chains, each with an iron-containing heme group. So each hemoglobin can transport 4 oxygens. Oxyhemoglobin is the hemoglobin-oxygen combination, and reduced hemoglobin is hemoglobin that has already released its oxygen. Loading and unloading of oxygen are facilitated by change in the shape of hemoglobin as the oxygen binds or is released. Fully saturated means that all 4 heme groups are carrying oxygen, and partially saturated means when only 1 to 2, 3 heme groups are carrying oxygen. The rate of loading and unloading of oxygen will be regulated to ensure adequate oxygen delivery to cells. And these are factors that you should know that influence hemoglobin saturation, the pressure of oxygen, temperature, blood pH, the partial pressure of carbon dioxide, and the concentration of BPG, which you do not need to know. The influence of pressure of oxygen on hemoglobin saturation, the pressure heavily influences binding and release of oxygen with hemoglobin, and the percent of hemoglobin saturation can be plotted against the pressure of oxygen concentrations. And the resulting graph will be an S-shaped curve, and we call this the oxygen hemoglobin dissociation curve that you can see here. So the amount of oxygen carried by hemoglobin depends on the amount of oxygen, that's PO2, available locally. This relationship ensures optimal oxygen pickup and delivery, and this oxygen dissociation curve will help you understand how the properties of hemoglobin affect oxygen binding in the lungs and the oxygen release. So the y-axis, this one, tells you how much oxygen is bound to hemoglobin, and at 100%, each hemoglobin has 4 bound oxygen molecules. In the lungs, where the pressure of oxygen is high, hemoglobin is almost fully saturated with oxygen. This axis, the x-axis, tells you the relative amount, the partial pressure of oxygen dissolved in the fluid surrounding the hemoglobin. And in the tissues of other organs where pressure of oxygen is low, hemoglobin will be less saturated. And if more oxygen is present, more oxygen is bound. However, because of hemoglobin's properties, oxygen binding strength changes with saturation, there will be this S-shaped curve. In arterial blood and in venous blood, we have pressures of hemoglobin and oxygen differ. The venous reserve refers to the oxygen remaining in venous blood that can still be used. In venous blood, hemoglobin is about 75% saturated, and in arterial blood, hemoglobin is about 98% saturated. So here it takes you through the oxygen dissociation curve. At high altitude, there's less oxygen at a pressure of oxygen in the lungs of only 80 millimeters mercury, so hemoglobin is still 95% saturated. And at sea level, there's lots of oxygen in the lungs, and hemoglobin is about 98% saturated. So, not a huge difference there at high or low altitude. In the tissues at resting or metabolically active, so at resting tissues, hemoglobin is about 75% saturated. And in metabolically active tissues, hemoglobin is only 40% saturated, meaning it has released a lot of its oxygen to the tissues that it's trying to give its oxygen to. Increases in temperature, hydrogen ions, partial pressure of carbon dioxide can also modify the structure of hemoglobin. They result in a decrease of hemoglobin's affinity for oxygen. This occurs in systemic capillaries. Basically, what an increase in temperature hydrogen ions does, it will enhance oxygen unloading, causing a shift in oxygen hemoglobin dissociation curves to the right, and a decrease in these factors shift the curve to the left, which will decrease oxygen unloading from the blood. So this takes us through body temperature. Normal body temperature is about 38, 37. Increases in temperature will increase oxygen unloading from hemoglobin, so that shifts the oxygen dissociation curve to the right. And decreases in temperature shift the oxygen dissociation curve to the left. And what that means is just that it is harder for oxygen to be unloaded to tissues in colder temperatures and much more easily in warmer temperatures. This takes us through pressures of carbon dioxide, which you can kind of look through decreased in carbon dioxide, shift it to the left, increased carbon dioxide, shift it to the right, again, offloading its oxygen. Influence of other factors of hemoglobin saturation, I'll let you read through those, but you don't have to know those ones. Carbon dioxide transport. I do want you to understand carbon dioxide transport. It's transported in the blood in three forms, dissolved in plasma as PCO2, and it's chemically bound to hemoglobin, and carbon dioxide is bound to the globin part of hemoglobin, and we refer to that as carbaminohemoglobin. But most of carbon dioxide is transferred in the blood as bicarbonate ions, and this is what I do want you to know. So in the blood, carbon dioxide is transported as bicarbonate ions. This is abbreviated HCO3 negative. The formation of bicarbonate involves carbon dioxide combining with water to form carbonic acid, which quickly dissociates into bicarbonate ion and this hydrogen ion. It will occur primarily in red blood cells where this enzyme is able to catalyze this reaction. And in systemic capillaries, after this bicarbonate is created, it quickly diffuses from red blood cells into the plasma. The outrush of bicarbonate ions from red blood cells will be balanced as chloride ions move into red blood cells from the plasma. And this is referred to as a chloride shift. So again, this just shows the carbon dioxide is normally bound or transported in the blood as a bicarbonate ion. And you can see that here through this equation, through this carbonic anhydrous, we get a really quick reaction to get bicarbonate ion. In pulmonary capillaries, the processes occur in reverse. So eventually we get carbon dioxide diffusing into the alveoli to be exhaled as air, and that is shown here. And I really want to talk about the influence of carbon dioxide on blood pH. So we have this carbonic acid bicarbonate buffer system, which helps the blood to resist changes in pH. If hydrogen ions concentration in the blood rises, excess hydrogen ions will be removed by combining it with this bicarbonate ion to form the carbonic acid, which will eventually dissociate into carbon dioxide and water. And if hydrogen ions concentrations begin to drop, this carbonic acid will dissociate, releasing the hydrogen. So we get this kind of buffer system due to how carbon dioxide is transported in the blood. Changes in your respiratory rate and depth will also affect your blood pH. So if you have slow, shallow breathing, that will cause your body to retain excess carbon dioxide in the blood, which will result to a drop in pH, meaning more acidic pH. And rapid deep breathing causes a decrease in carbon dioxide because your body is ridding itself of excess CO2, and that will result in a rise in pH. Changes in ventilation can help adjust pH when disturbances are caused by metabolic factors. So breathing will play a huge role in the acid-base balance of the body, and that's why we talk about this with the respiratory system. Hypoxia is inadequate oxygen delivery to tissues, which can result in cyanosis, which is kind of a bluing of the skin, and is classified by cause. We have anemic hypoxia, ischemic hypoxia, histotoxic hypoxia, hypoxemic hypoxia, and carbon monoxide poisoning. I want you to know a little bit about carbon monoxide poisoning. Um, Carbon monoxide poisoning occurs because hemoglobin has about a 200 times greater affinity for carbon monoxide than oxygen. Victims will have headaches, can become flush, but what's going on in carbon monoxide poisoning is their hemoglobin is binding more tightly to carbon monoxide than to anything else. This is a great gas exchange video that you can look at when you download the PowerPoint. Control of respiration. These respiratory rhythms are regulated by higher brain centers, chemoreceptors, and other reflexes. We have the medullary respiratory center and the medulla, two different groups, ventral and dorsal respiratory group. Here's the ventral respiratory group and the dorsal respiratory group. You don't need to know too much about those or more any of the neural, but you should know that the respiratory centers are controlled in the brainstem of the medulla. The respiratory rhythm is not fully understood. There could be pacemakers in one of these respiratory control groups. Depth is determined by how actively your respiratory center stimulates the respiratory muscles. The rate is determined by how long the center is active, and both are modified by changing body demands. The respiratory centers are affected by chemical factors, other higher brain centers, pulmonary irritant reflexes, and inflammation reflex. And these are the different chemical effectors located throughout the brainstem, the aortic arch, the carotid arteries that can influence breathing depth and rate of inspiration. The influence of carbon dioxide is probably the most potent and most closely controlled. If blood carbon dioxide levels rise, carbon dioxide will accumulate in your brain and join with water to become carbonic acid. This will release hydrogen ions, causing a drop in pH and increased acidity. This increased acidity and hydrogen ions will stimulate chemoreceptors of your brainstem, which will synapse with respiratory regulatory centers, and they will tell your respiratory centers to increase depth and rate of breathing, which will try to act to lower your blood carbon dioxide levels, and pH will eventually rise to normal. If blood carbon dioxide levels decrease, respiration becomes slow and shallow. Apnea is breathing cessation that may occur when carbon dioxide levels drop abnormally low. Swimmers sometimes voluntarily hyperventilate to enable them to hold their breath longer. This will cause a drop in their carbon dioxide levels, which cause a delay in respiration as carbon dioxide levels need to build back up. But this can cause dangerous drops in your oxygen levels. Hyperventilation is the increased depth and rate of breathing that will exceed the body's need to remove carbon dioxide. It could be caused by an anxiety attack. It will lead to decreased blood carbon dioxide levels as you're breathing out carbon dioxide quickly. It can cause dizziness, fainting, tingling, and involuntary muscle spasms. The treatment is usually breathing into a paper bag to try to increase carbon dioxide levels. So you're trying to breathe into a paper bag so that what you're exhaling as CO2, you try to breathe some of that back in. Here's some chemical factors. Not going to ask you too many more details about those. Influence of arterial pH. pH can modify respiratory rate and rhythm, even if carbon dioxide and oxygen levels are normal. Decreased pH may reflect carbon dioxide retention, accumulation of lactic acid, or excess ketone bodies, and respiratory systems will control the attempt to raise pH by increasing the respiratory rate and depth. So here's a summary of chemical factors. The influence of higher brain centers through your hypothalamic control, cortical controls. Pulmonary irritant reflexes are receptors in your bronchioles that respond to irritants like dust, mucus, or noxious fumes. They will promote a reflexive constriction of air passages. And the same irritant will trigger a cough in your trachea or bronchi, or a sneeze in the nasal cavity. This is the inflation reflex it sends inhibitory signals to the medullary respiratory centers to end inhalation and allow expiration. And it could act as a protective response more than as a normal regulatory mechanism, but you don't have to know too much about that. Respiratory adjustments, a couple adjustments that you need. We'll talk a little bit about exercise. Adjustments are geared to both intensity and duration. Hyperpnea is increased ventilation in response to metabolic needs. Ventilation will increase abruptly, increase gradually, and then reaches a steady state. And when exercise stops, there's a small abrupt decline in ventilation. So this is just your body's way of breathing more to try to increase oxygen demands. There's an abrupt increase in ventilation that occurs as exercise begins, and it involves these three neural factors. Don't really need to know those. It'll decline, and then eventually could lead to lactic acid from lack of oxygen in the muscles. High altitude, quick travel to altitudes above 24 meters may trigger symptoms of acute mountain sickness. This could be headaches, shortness of breath, nausea, and dyspnea. This is when atmospheric pressure and oxygen levels are lower at high elevations. Um, I'm actually recording this from Salt Lake City right now because my family's in the process of moving, and I can tell it's a little bit higher elevation here. We're about 6,000 feet. Acclimation or acclimatization are adjustments made with long-term moves to high altitude. So just your body's ability to adjust eventually to that high altitude. Um, they always result in a lower than normal hemoglobin saturation level. So that is just due to the availability of less oxygen. So a decline in oxygen will stimulate your kidneys to accelerate the production of erythropoietin. And remember, erythropoietin is the hormone that produces red blood cells. So red blood cell numbers will increase slowly to provide long-term compensation. This is why athletes a lot of times exercise and train at high altitudes because they are forcing their red their body to create more red blood cells and more hemoglobin to carry oxygen. Lung diseases, a couple of these you should know. Chronic obstructive pulmonary disease is a big one that you'll hear about, I'm sure. COPD. It's exemplified by chronic emphysema and chronic bronchitis. The key feature is irreversible decrease in the ability to force air out of your lungs. There's a history of smoking in about 80% of patients. Dyspnea is labored breathing, coughing, and frequent pulmonary infections. Most patients develop hypoventilation along with respiratory acidosis and hypoxemia. So basically, what's happening is there's labored breathing. You're retaining too much carbon dioxide in your lungs, which is decreasing your blood pH. And hypoxemia, you have decreased levels of oxygen. Emphysema is the permanent enlargement of alveoli and destruction of alveolar walls, which will result in decreased lung elasticity with three different consequences. Your accessory muscles are necessary for breathing, lead to exhaustion. Trapped air causes hyperinflation. Damaged pulmonary capillaries lead to enlarged right ventricle. Chronic bronchitis is just an inflammation of the bronchioles, usually due to an inhaled irritant. The mucosa becomes inflamed, fibrosed, scar tissue forms. It results in obstructive airways that impair lung ventilation and gas exchange. Symptoms include frequent pulmonary infections. Smoking and environmental pollutants are a big thing that cause that. COPD symptoms and treatment. Um, Pink puffers, the patient is usually thin because they burn a large amount of energy breathing. Blue bloaters, the patient is usually stocky and they're seen as cyanosis due to hypoxia. Treatment is to dilate the bronchioles, corticosteroids to also help with bronchial dilation. Oxygen, sometimes lung volume reduction surgery, and oxygen must be administered very carefully. So here's the pathogenesis of COPD, some of the things that might cause it, a deficiency, if it's a hereditary, and then what it can eventually lead to. Asthma, sometimes classified as COPD, but the episodes are usually more acute. Coughing, dyspnea, wheezing, chest tightness. This is acute inflammation of airways. The inflammation is an immune response caused by a release of interleukins. The airways are thickened with inflammatory exudate, and that will magnify the effect of bronchospasms. Tuberculosis is an infectious disease caused by a bacteria. Symptoms include fever, night sweats, weight loss, racking cough, coughing up blood. Treatment is usually a 12-month course of antibiotics. Lung cancer is the leading cause of cancer deaths in North America. 90% result from smoking. Adenocarcinoma, squamous cell carcinoma, and small cell carcinoma. Treatment for lung cancer, early detection is key. If metastasis has not occurred, usually surgery to remove the diseased lung, radiation and chemotherapy. Sleep apnea is a common disorder characterized by temporary cessation of breathing during sleep. The person is usually not aware of this problem. It can lead to excessive daytime sleepiness. Obstructive sleep apnea is the most common type, caused by the collapse of the upper airway, where the pharynx muscles relax during sleep and will sag, causing an obstruction. Central sleep apnea, caused by a reduced drive from the respiratory brain centers. Obstructive sleep apnea can usually be treated by using a continuous positive airway pressure device to help keep the airway open. Very uncomfortable, but that's what people can use when they sleep. Thanks for listening to this chapter, chapter 21, and we'll see you for the next recording or in class.